We're not doing a live, right, Faisal? We're not going to go live. We're not going to go live, right? We're just doing the recording. Hey, babe.
Yeah. Well, why don't we just do the recording? Yeah.
Okay, sounds good. Yeah. Okay,
Yeah,
baby. I'll
okay.
just come over.
Okay, perfect. Well, welcome everyone. My name is Faisa Farole, and I am with Global Perinatal Services. We're here another Saturday at Mom's Corner. Global Perinatal Services, or GPS, is a nonprofit organization that provides doula services to predominantly Black, refugee, and immigrant families across in King County and some Pierce County now. That we do, and we have our awesome doctors from Swedish. We do this once a month, and they have prepared a topic for us today about induction and C-sections. And they're going to do their presentation, and then we'll ask any questions that we have. So Doctors Jasmine and Susie, please take it away.
Hi there.
Hi.
So yes, we're going to talk about indications mostly for induction, a little bit about like how we think about like methods of induction and what would prompt us to use one or the other. And just like really a very short bit on C-sections. I've only scrubbed in on a few C-sections, and I think that probably could be like a topic on its own, but I'd put a little bit here on C-sections just because usually that if we can't do an induction, typically then the next step would be to do a C-section, although I have seen some people come in for an induction and they, you know, I sometimes the phrase is like a failed induction, or I don't know, it's maybe nicer to say like an unsuccessful induction. And I have seen that happen where then they go home and then they can come back and try again later, depending on how that induction went and how far along they were in that process. Yeah. Is there any questions before we get started about this?
I think since yeah, just the situations that warrant, you know, an induction or C-sections, and yeah, I think starting off with that would be ideal.
Yeah, perfect. That's exactly what we're going to talk about. All right, let's see here. Okay. Can you guys see the full slide, or is like as our face is like covering it, part of the slide? Okay, is that better?
Yeah, we can see it. You can do the presentation mode because we can see some of your desktop too.
Okay, let me see here. Because they do know how to do presentation mode. Here. That's like live.
I think it's to the right, all the way to the right.
Oh, to the right.
Yeah, no, right here. Right, yeah, I think that should be. No? Oh no, that's the end. Okay.
Nope. Let me try it. I think if I did this, if I exit out,
I'll go there we go.
And then I'll do.
It should be right there to the right.
Present.
Yeah.
Okay.
Yeah, perfect.
Yeah, group teamwork.
I know.
Okay. Okay, so there are many indications for inductions, and so we'll talk about the most common. So starting with oligohydramnios, which is basically like not enough fluid, like amniotic fluid that surrounds the baby. And the timing for induction that is recommended is to be induced between 36 weeks to 37 weeks and 6 days. Or if you find out that later on, like past that time frame that you have oligo, then they recommend induction at that time. The opposite of oligo is polyhydramnios, and that's too much fluid. And So the timing for that induction is 39 weeks to 39 weeks and 6 days. And then IUGR stands for intrauterine growth restriction. And then there's certain classifications of like, sometimes like IUGR that is uncomplicated, no other issues going on with the baby or the pregnant person. And that recommendation for induction time period is 38 weeks to 39 weeks and 6 days. And so on some of these slides, I try to talk a little bit about each of these things. I didn't make one for every single indication, but oligo, like it's pretty common to see people with oligo or polyhydramnios. For oligo, there are different causes that could cause oligo. And you can see some of the causes here. So like there's on the maternal side, some certain conditions that can cause that. So like ureteroplacental insufficiency. So things like preeclampsia, things like if you had high blood pressure before you got pregnant, some that like connective tissue diseases that affect your blood vessels, kidney issues, some bleeding disorders. Sometimes some medications can cause oligohydramnios as well. There are issues with the placenta that can cause oligo, so like placental abruption. Sometimes people get microabruptions as well. A condition called twin-to-twin transfusion. Things going on with the baby. It can be like chromosomal abnormalities, like issues with the baby's kidneys. And so if the baby is not urinating in the womb, then that can lead to oligohydramnios. Growth restrictions. Sometimes if there is fetal demise, if you go too long in your pregnancy, and post-term is like officially diagnosed as anything past 42 weeks. Late term is 41 weeks to 42 weeks. Anemia, infections, and sometimes people like we don't know. Idiopathic is like we don't know why. We've ruled out all these other possible causes for why there isn't enough fluid that is surrounding the baby. And to diagnose oligo, I put a little bit here. There's like objective findings that we look on ultrasound, and then subjective findings for the diagnosis. It's always preferred to use something like that. We have like actual like data to measure for the diagnosis. So when you are getting your scans, they will look for, there's certain, pockets that surround the baby in your ultrasound, and we find the single deepest pocket. If the single deepest pocket that of fluid that surrounds the baby is less than 2 centimeters, or the amniotic fluid index is less than or equal to 5 centimeters, that would be like an objective criteria for oligohydramnios.
So some other indications for induction. So like we said before, the intrauterine growth restriction. But another indication, not just if it's uncomplicated, but also if there's abnormal Dopplers, which means that there is some blood flow abnormalities, either going from or to baby. Then your date for induction actually moves up into 32 weeks, depending on how bad the severity is. If you've had prior C-sections and you want to give a go and try to do a vaginal birth or try to do an induction, then we do try to do the induction a little bit earlier at 36 to 37 weeks. And if you have some issues like hypertension, whether or not you're on meds, then we typically recommend an induction. And that's because hypertension can affect the pressures that the babies are experiencing and also how well the placenta works. So if you're not on meds, but you have hypertension, then we recommend between 38 and 39 and 6 weeks. But if you're on meds, then we recommend it a little bit earlier at 37 to 39 and 6. So you can start your induction a little bit earlier. If you have gestational hypertension, so that means that you didn't have high blood pressure before you were pregnant, but you do now that you are pregnant. And that happens with a lot of women. And sometimes it'll resolve after pregnancy, but sometimes it won't, and it'll turn into regular hypertension for them. But if you have this high blood pressure during pregnancy and you don't have any severe ranges, meaning really high blood pressures, then we recommend about 37 weeks or later if you're diagnosed later. If you do have severe range blood pressures, and that means that your blood pressures are really high, then normally we try to get the baby out a lot earlier. So 34 weeks if you were diagnosed before then, or when you have the diagnosis of having the severe range blood pressure.
All right. Go ahead.
The one other thing I wanted to mention was, we oftentimes will, do a trial of labor for after a cesarean. And for this indication of a prior classical C-section, most of the time, I'll use my, you'll see a C-section cut pretty low, like a low transverse cut. Mm-hmm. That's what people try to do. The old version, classical, for sometimes from emergency reasons or whatever, people need to make a vertical incision. That's called a classic C-section incision. And so the indication is 36 or 37 because when you make a line down the middle, that actually is a little bit more dangerous for doing a trial of labor because of the way the uterus contracts. It's in the contractile force of the uterine muscle. And so that it leads to increased risk for uterine rupture during labor.
And is that a form that is done, the vertical one, when there is any of these indications? Is that, or that's just something that's used in an emergency situation?
I honestly haven't seen anyone that has done a trial of labor with me with a classical incision. Usually those are emergent situations where they do that.
And it used to be a lot more common to do classical C-sections in the 70s and 80s. So you'll see women who have those scars, and then abroad, depending on situation and training and resources, classical might be preferred for a lot of different reasons. In the US, though, classical is really reserved for if you need to get the baby out immediately, because even with a transverse C-section, which is what we normally do, you can bet on getting the baby out within less than 2 minutes most of the time. So if it needs to be less than that, then you might do a classical.
Okay. Some questions that I hear through our doulas, or their clients would have, one is about the IUG or the inner uterine growth retardation. The fact that their doctors would tell them they need to come in to get baby out. And so when people are wouldn't it be better if a baby stays inside of me and you monitor me? You want to talk a bit about that, why you all would recommend the baby to be born rather than keeping it inside mom with that condition?
Yeah, so it kind of also depends on what is the cause of the the growth restriction. But there's sometimes more, as you go farther along in the pregnancy, there can be more complications and stress on the baby during delivery. than if you were to induce earlier on.
And so when we say that there's growth restriction, it means that there's something that's not allowing the baby to grow. And although it would be great to be able to fix whatever that problem is and then have baby grow in the uterus, I think when we say that it's more likely that it's better for us to get baby out, it's because whatever is restricting the baby's growth is something that probably won't get better. So rather than let the baby grow under the pressure of whatever it is that's keeping him or her not able to grow correctly, the idea is let's let them out as early as it's safe, where they can then grow freely without that added pressure.
So like,
Thank you.
you know, and that's kind of like where the caveat there, it says like as early as 32 weeks, because, you know, like the viability of a baby and like maturity and what we have in terms of like technology to assist baby, you know, I think the outcomes are better at 32 weeks than staying in the womb, because exactly like Dr. Greenman was saying, and like if there was an issue with like the placenta, as you get farther along, you know, your placenta like kind of gets older and those vessels kind of start breaking down. And you'll see that, I don't know if anyone has seen like someone that maybe like came in for like a late term or post date induction, and if you know, we oftentimes like show them the placenta, like, you know, this is the thing that was like nourishing your baby while inside, and you'll see like calcifications in the placenta, and it's like the sign that is, it's like it's like, you know, it's only meant for like a certain amount of time, you know, so that's like another reason. But there are a lot of reasons for the growth restriction, and that kind of determines like how long they would recommend. And usually if there's something like intrauterine growth restriction, we would have the parent see maternal fetal medicine to kind of have a person that specializes in things like this look at the indications, think about like the reasons, maybe do some additional workup, and then from there recommend like here is what you might want to when you might want to consider doing an induction based on the safety profile.
All right, thank you. Yeah, because that's one that comes up a lot with, you know, when a client has been diagnosed with that condition. So yeah.
It's a tough one. It's a really broad category that can be different, varying amounts of scary. You know, is it just because there's twins and there's just not enough physical room in your belly? You know, that's not nearly as scary as something like your placenta isn't doing what it should. So there's a lot of variation.
Okay, so more indications for induction would be preeclampsia without severe features, and we'll get to like what we mean by severe features, and preeclampsia with severe features. The difference between those two in terms of the timing is that without they recommend induction at 37 weeks, with severe features 34 weeks. And pre-gestational diabetes that's well controlled, then the recommendation is 39 to 36. Poorly controlled pre-gestational diabetes, 36 to 38 weeks in 6 days. And GDMA1, which is gestational diabetes that is just controlled with diet. So you were diagnosed with gestational diabetes during the pregnancy, and you've been able to maintain, you know, good glucose control just with like diet and exercise. That recommendation for induction is 39 weeks to 40 weeks in 6 days. It's just a week early if you have gestational diabetes, with that you need to control with medication. So 39 weeks to 39 weeks in 6 days.
Do you want to talk a bit about what with or without features
Yeah.
are as far as the preeclampsia? Yeah.
Yeah, exactly. Great question. So preeclampsia is it's a pretty broad diagnosis, and we call it preeclampsia because the eclampsia is when this gets so bad that a lot of times you can have something like seizures. But before you end up to the point where you have eclampsia, there's a big range of preeclampsia with and without severe features. So preeclampsia is when you're going to have high blood pressures. And in order for us to say that it's high blood pressures, you need to have more than one high blood pressure, and it needs to be more than 4 hours apart. So if you come in and you're just really stressed out because you were late, that doesn't mean you have preeclampsia if you have one high blood pressure. It needs to be separated by a certain amount of time. A lot of times people with preeclampsia will have things that kind of look like they're having a migraine with like different flashes of lights, or floaters, or different parts of their visual fields cutting out. And that has to do with how the blood pressure is affecting the eyes. And you can have a really bad headache that might not respond to different sorts of like ibuprofen or migraine medications. But it also affects other parts of your body too. So you can have some liver problems where your liver enzymes, which is a marker of how stressed your liver is, those will go up, telling us that your liver is under stress. And sometimes you can have some pain around where your liver is, right in the right upper quadrant. Another marker is thrombocytopenia. So platelets are types of blood cells. And you end up having low platelets, and this is something that can happen pretty quickly. But you can also have things like renal, so your kidneys can have some damage, and that's pretty common with any type of high blood pressure. And then you can have pulmonary edema, meaning that you have fluid built up in your lungs. So these are all the scary things that can happen, the severe features. So if somebody comes in just with preeclampsia, normally what we mean is they have some high blood pressures, and we want to keep an eye on them. But as soon as they start experiencing any of these other symptoms, the weird vision flashes, the headaches, any sort of pain, or we start seeing those changes in their labs, that's when we say that it's severe features, and it's a little bit more pressing to get the baby out.
And in terms of like hypertensive disorders of pregnancy, so like issues with high blood pressure during pregnancy, there's a range. So chronic hypertension is high blood pressure before, like you had high blood pressure before you got pregnant, or if you were diagnosed with high blood pressure before 20 weeks, before you hit your 20-week mark. That's called chronic hypertension. And then you have gestational hypertension. And so that is after 20 weeks, you have had a blood pressure of 140 systolic, so the top number, over 90. And that is, you had that twice, at least 4 hours apart from each other. That gives you the diagnosis of gestational hypertension. When we go into what we call preeclampsia, that is basically gestational hypertension plus like protein in your urine. There's like certain lab findings that are associated with that. And then with severe features, it's basically, you just keep adding a layer on. So you've got the preeclampsia, and severe features can be a diagnosis of the 160/110, whereas before, like it's 140/90, right? And typically, once you hit a severe range pressure, the like typical guidance is like you want to wait like 4 hours apart to make sure that's right. But because there is a special caveat, because 160/10 is very high, you can actually just hit that blood pressure monitor again. And if it's 2 minutes apart and it's still high, technically you've checked off the box for boom, like that's a severe range pressure, that's a severe feature. You can have preeclampsia, not have the high blood pressure, but if any of you hit any of these other problems, that's considered severe features. And let's say you were in labor and you were doing an induction, and one of those things happened during the induction. The thing that we would do then is start a magnesium infusion protocol. And magnesium helps protect you from having a seizure, the eclampsia part. This is the scary part. We don't want you to have a seizure. The treatment for preeclampsia is getting the baby out. And so that is why we have induction early, because the way to treat this, to protect mama or the parent and the baby, is to get the baby out as safely, or as early as possible in the safest gestational range. Yeah, Asia, you have a question?
Yes, hi. So my question is, does preeclampsia happen during postpartum, or like after mom delivers? Or and if it does, is it common?
Yeah, so great question. It's very common for people to have high blood pressures, like meet the criteria for preeclampsia even after delivery. You know, typically Swedish now, it's not a hard rule, but it is, I've been seeing more and more of our Swedish laborists, if somebody had any gestational disorder, like blood pressure disorder, they keep them at least for 2 days, because after you have a baby, there's lots of fluid shifts and your blood pressure is going to range pretty wildly. And so they just want to monitor that blood pressure for a little bit longer. And you know, I'm on OB right now, and I saw someone that like had preeclampsia. They weren't on any, they were actually diagnosed with preeclampsia during, like, at triage because of protein in their urine. So before that, they had gestational hypertension. Then they went for the induction. And so they weren't on any medication before that, you know, and their blood pressures were controlled relatively, but they ended up having the protein in their urine. And then they had their induction, and then their blood pressure was just like consistently like right close to that severe range pressure after baby was born for 24 hours. And so then the laborists decided, okay, we'll keep it for another day. We're going to give you some high blood pressure medications, labetalol, which is really a medication that I only see used in pregnancy for blood pressure management. And then we watched her for a little bit longer. Her blood pressures looked really great with that medication on, and she was going to go home the next day. She had a blood pressure monitoring kit previously because she had gestational hypertension, and she was going to monitor her blood pressure. And then she had a sooner follow up with her doctor than the typical 6 weeks. She was going to see them in 1 week and talk about her blood pressures, and if they look good, she could stay on that dose for 6 weeks. And if they didn't seem controlled in some way, they could increase either the amount of the labetalol or how many times a day she was going to take that labetalol. Did I answer that question?
Yes, you did. Thank you.
My turn. Okay. I'll go. So the next one is cholestasis of pregnancy. That's also a pretty common one. It's like issues with, you know, your gallbladder, like you get very itchy hands and feet and skin, and the indication for delivery for that is 36 weeks to 37 weeks. or as soon as you get diagnosed with that, if you're before time of delivery. Any twins, and then the type of twin, like di, mono, that all is like related to like, do the twins share a placenta? Do they have their own placenta? Things like that. HIV, if you haven't broken your water, and your viral load is greater than 1,000, they recommend a C-section. If you're HIV positive, you have a viral load less than 1,000 and you're on antiretroviral treatment, you don't have to come in for an induction. You can just do a full-term vaginal delivery.
Any questions on the reasons that we would do an induction?
Yeah, I have a question. Most of our clients, when they hear induction, they just they feel like it's gonna be very painful, and maybe uterus will rupture, even though it starts slowly. But they have that mentality that even if it's helpful, still there's a resistance there that they don't want to be induced. And so if you could just explain a little bit more the risks and also the benefits of this.
So
Thank you.
it's certainly not our goal with induction to cause pain or to make labor any worse than it already is. The goal in induction of labor is to try to move the time up that you have the baby and make it happen a little bit earlier. Sometimes we can also speed things along. So the way that we do induction is we normally use, we'll start it depends basically on where you're starting. And when we say where you're starting, that means how dilated is your cervix already. So if you had indications for induction, but your cervix wasn't dilated at all, then the first thing that we would do is try to get your cervix dilated a little bit. And we would use medications like misoprostol to try to get your cervix to soften and ripen and change a little bit and try to open. So when we do that, we can do multiple rounds of that. That can sometimes cause some mild cramping, but for the most part, people don't experience a lot of discomfort with that. So after a couple hours of that, hopefully you've seen some change. And depending on how much change there is, we can get the cervix to open further in a couple of different ways. If you're not quite at 4 centimeters, which is kind of the magic number for starting oxytocin, or Pitocin, which is the synthetic oxytocin, then we can try to help your cervix get a little bit more open, continuing with the misoprostol, or we can do a couple other things, which we'll talk about in the next slide. But the goal is to get your cervix to about 4 centimeters dilated. And then once you're there, then we augment your induction by adding Pitocin, which is basically, it's the same chemical structure of oxytocin, which your brain makes when it goes into labor. And that tells your brain, that tells your placenta, that tells your uterus, it tells everybody involved that, hey, it's time to deliver this baby. Let's start dilating, let's start pushing and having contractions, and get this baby out. And I think the part of the question that you had about leading to cervix, your uterus having issues. So we normally try to dose the Pitocin in a way that we can control how far apart your contractions are and how strong they are. So that way we can control how much stress your uterus is going under, so that something like that wouldn't happen. And a lot of times that's why people are on the monitors when things are getting pretty intense.
Yeah, and so kind of to go along with that, one thing that you might have heard from your clients, like before even induction, is like, you know, the doctor will do a cervical check and talk about a Bishop score. And I have an app that like MD Calc, it has a bunch of like medical type of calculators for different criteria for different things. And I have my Bishop score one starred because we use it a lot on which way are we going to go with this induction. And so the components of the Bishop score are dilation. So that's like how far apart is like your cervix dilated. And for example, like a closed cervix is 0, 5 or greater gives you 3 points. Effacement, how thinned out is your cervix? 0 to 30% thinned out is a score of 0. 80% or greater is a score of 3. And you know, obviously, I'm skipping the parts in the middle, but just to kind of give you an idea of like the scoring system. The station, so that's like how far high is the baby in your pelvis. -3 to the like ischial spine is a 0 score, and like +1, +2 is +3 score. Position, so there's like posterior, mid position, or anterior position. Posterior is 0 and anterior position is +2. And how does the cervix feel? So firm, I was told like firm, think about like your forehead, and moderately firm or like medium is like your nose. So that's like typically how your cervix normally feels, is like your nose. And then soft is like your cheek, or like the inside of your cheek. That's a very soft cervix. So firm is 0, and soft is 2 points. And you add all those up for your cervical check. And if it's less than 6, a score of less than 6, then you want to try and think about like ripening that cervix up. And there's 2 ways to do that, typically with like a mechanical method, and that is with a Foley balloon. And so we have a little like noodle looking catheter that we insert into the cervix. Like it's, you know, the cervix is like a little donut. We insert it in there. We put a little water in there, and it balloons up kind of like this big. And then it sits on the inside part of the cervix, and that just kind of simulates what baby would do, as like, you know, baby is putting pressure on that inside of the cervix, and that kind of sends signals for the cervix to soften and dilate. Another method that Dr. Green was talking about is misoprostol. There's been a lot of studies on like, is it buccal method misoprostol, where you put the medication between your gum and your cheek, or vaginally. There's a lot of studies that say there's no difference. There's a lot of studies that say vaginal is best. I think like it is like research wise, it's a tiny bit better to do vaginal meso. And some people will say that there's less GI side effects with vaginal meso, and they just, you know, place it into the vagina, that medication, and it gets absorbed that way. And then typically, depending on your contractions, how frequent your contractions are, they'll do that every 4 hours. And most people come in for their inductions kind of like in the evening time, and they get the vaginal meso, and they go to sleep. There might be some mild cramping, but that is also what you would expect at home if you were to just kind of, your body was going to be, you know, dilating at home before you came in active labor as well. Now, there are some caveats with that. For example, we had a lot of questions on intrauterine growth restriction. We don't use misoprostol for an induction with intrauterine growth restriction typically, because once your body has the misoprostol in it, we dose it every 4 hours, right? And we monitor the frequency of those contractions. And when you have a baby, where any kind of stress on that baby can be dangerous to baby, once you put a medication in there, you can't take it back. So we always try to do a mechanical first, or you would do I've seen sometimes Pitocin. And the reason why we would use Pitocin, even if your cervix is less than 6, is because Pitocin can come into your system and it can leave your system very quickly, way quicker than misoprostol can. And so if we're like, oh, baby's not liking that, we just turn it off and we wait, and then we can like change the plan a little bit faster than, oh, we gave you this misoprostol and we have to just wait for your body to metabolize it out. Any questions on that?
I think Binta had her hand up for a while.
Yes, hello everybody. This is
Hi.
Bintan. I'm a licensed midwife.
Joining us all the way from West Africa. What are you doing here?
I saw your message. I'm like, okay, how can I log in? Oh, so sorry, I'm late.
No, welcome.
This is a great topic. So I have my practice on the Soto area in Seattle. I didn't get to hear your introduction at the beginning, but do you mind going back to the slide before this one, please? My question was about that.
Yeah, let's see here. Really, here we go. Hold on.
Like it was like indication for
This one?
yes, that one. Because I have quite a question. Maybe you already answered it. Because of my clients, and I'm a doula as well with GPS. And I tend to see induction being going because of suspected of baby size. I'm seeing that quite a bit, which study has not, I follow the literature, but it was like, what is your intake on that? Like, do we need to prepare our hospital birth folks for that? Is that gonna be a new thing now? Like, how can we warn them? How can we, is that a thing? I didn't see that in your list. That's why I'm like, but it's happening though in a lot of places now.
You mean like the baby is too small or the baby is too big?
They expect the baby to be big, but then baby will come out and baby will be like 1 pound less than what they even estimated it.
I guess I haven't seen that. I know that, like, obviously if we were like, oh, this baby, there's concern for, macrosomia or like a big baby, we obviously, want to make sure that you don't go past the time, like post dates or anything. Like, you can start, if you have, everything is fine and normal, you can do an induction at 41 weeks, which is considered a late term induction for late term. And that's because the baby will just keep growing and growing, and then you have risks of a shoulder dystocia. You have
and that is because we are if there is macrosomia or there's gestational diabetes, right? Because we all know the side effect of having untreated or uncontrolled gestational diabetes, right? I'm a licensed midwife and I do practice as well. But my thing is like, how are we using the terminology as you having a big baby by palpating a belly and pushing for induction at barely like 39 weeks, like that mark, which will lead to other complication of induction, which will lead to C-section. And and the community that we serve, right, the immigrants, the refugees, and the Black and the BIPOC community, it's bringing a toll. And then the minute the baby is born, everybody in the room be like, and the way the baby is like, we have a small for gestational age baby now because of the way it's so dramatically lower. It's not a 9-pound baby. Now we are having a low 6-pound baby,
Mhm.
right? So I'm just trying to say, what is your intake on that?
Yeah.
Is this the new stuff?
So there isn't an indication to deliver like for before 41 weeks
Mhm.
for estimated fetal weight, concern for macrosomia, for induction for that reason. There is indication
Mhm.
for gestational diabetes, and that's not because of the baby size. That's because of like other complications that can happen. Of course, you have a big risk of macrosomia when you have gestational diabetes, or you had.
There is no control, right? There is no control or manage, right?
If it's not, well, it can be, you can have a large baby regardless of whether it's
Exactly.
controlled or not.
Mhm.
But it's more likely if it's uncontrolled.
Yeah, and you can have a big baby if you don't have gestational diabetes or prediabetes or anything like that, and that's why that's
Yeah.
not an indication for
Mhm.
for an induction. Like the indication would be for gestational diabetes, not for a big baby.
It
Okay.
sounds to me like you were also talking a little bit about the way that they're measuring babies. And I know in the last couple of years, we've really tried to move away from using Leopold's for estimating fetal weight, just because studies have shown that it's not very accurate. But having said that, while a ultrasound is more accurate, you can still be off by quite a lot with ultrasounds. So the ways that we try to get an idea of how big the baby is in general is pretty flawed, and we do the best that we can, but it can be off.
Yeah, no, for sure, because it is affecting the community that I do serve, and I'm just like how to better collaborate, about in that level or preparing them, or being pushed. Oh my goodness, I'm 39 weeks, I'm 40 weeks today and in 0 day, and like, or 1 day 40 and 2 days. Oh my goodness, they say I'm past my due date, and we are talking about induction. And then my question was always like, why? Can you tell me any clinical reason? Um, and as a provider, right? Like none of these things that you are listed as medically related is being mentioned. It's always like, oh, they think I'm going to have a big baby if I go like that. Like, no, you are 40 and two days, and the baby is fine, the NSTs are fine, the BPP is fine. Like, then why are we doing induction? Then they will end up with long term of hospital stay, and there are folks who might not afford postpartum support, postpartum doula. It's just being a pandemic right now. But anyway, sorry. Yeah, thank you for answering that though.
No, you bring up very good points, and there's a lot to unpack there, and I think that we could probably do a whole talk on just that. The dangers with allowing a large baby go past term, so after 41 weeks, is that the longer it goes, the more likely there are to be complications with vaginal delivery. So you can have like a shoulder dystocia or failure to descend. If baby is too big, they can just have a hard time getting through the pelvis, leading to a higher likelihood of needing a C-section. But like Dr. Abraham said, the size of the baby is not necessarily shouldn't by the data that we already have, shouldn't tell us that we should be inducing at 39 versus 40 weeks. But if you do have a large baby, maybe don't wait to 42 weeks and maybe have your induction at 41 weeks.
Yeah,
And again,
because
like,
shoulder dystocia is no joke, you know, for women who've had it, and also for providers who attend births with shoulder dystocia. It's pretty. It can get pretty nasty. So yeah.
and again, you know, like, I think this is the great reason why, like, I love being able to have these conversations and provide this information, because arming yourself with like the information, the data, will help you to, you know, to talk to your clients and advocate for them on like, here's the information. How can you make an informed decision for yourself if you don't have the information? And, you know, you said, okay, if the BPPs are good, if the NSTs are good, like, you know, the risks and the benefits, and you can make that decision for yourself. As long as you know, like, then I support like my patients that if they're like, yeah, here's the indication, here's the data that we say, you know, everything is fine with the baby. Yeah, we're concerned about it being big, but here's what you should do. As long as they know, like, there's a increased risk for shoulder dystocia, which means that that's increased risk for like baby and mom and C-section. But if they are like, I want to do this vaginal delivery, I'm like, let's go, mom, let's do this vaginal delivery then. But I want you to know that, like, here's all the information for you to make the best decision for yourself.
That's really awesome, Dr. Abraham, to know that that's the way you, that's the way you'll do, you know what I mean? Giving the information and then letting the client sort of decide.
Let's see here. So here's, this is, I tried many ways to try and format this so it wasn't blurry, so I apologize. I even have to kind of get close to the screen to totally read it, but it's basically what we were talking about, kind of like the pathway. Here's Bishop score of 6 or less, mechanical, or, you know, the misoprostol. You know, we can, I often do both. We'll put a Foley, and then we'll do also like the balloon, and we'll also do the miso. You know, there's, and then kind of going back home. And this is what I was saying, like, oh, you have no change, then you can go home. Or if you want, you can have a C-section, but most people want to go home and try again later, as long as it's safe, you know. And these are like the different pathways that you can take. We kind of talked about all of these different methods. So the Foley balloon, basically, one thing that I'll just add, let me move this up here so you can see all the text, is that it's going to dilate to 3 centimeters, and then it will fall out after 3 centimeters. I like the Foley balloon because it's in there, and they just, you know, the little part that comes out of the vagina, they just tape it to your leg, and you can do all the things. You can sleep, you can walk around, you can get on the birthing ball, you know, you can get in the tub, like you can do all of those things that you want to do, and not have to worry about, oh, I have this plan of how I want to go through labor, and it's not going to impact that. Same with the misoprostol. And, you know, the cervical ripening, you still can use Pitocin, but we would use low dose Pitocin. Like sometimes I say, like, it's like a whiff of Pitocin, like 1, but the maximum in terms of low dose is 10 millunits per minute. But again, like, Pitocin isn't great at dilating the cervix, but, you know, it's nice because you can turn it off. Whereas, like I was saying, if you give someone misoprostol and your uterus is contracting really fast because it's working, the medication's working really great, but that can stress the baby out when your uterus is contracting too fast. So that would be a reason why we wouldn't want to use it for things like intrauterine growth restriction, or sometimes even like a trial of labor, depending on what's going on. Let's see here. You'll see on the slide, 2 slides ago, on that little like chart, it will say like failed induction. I don't like that word, failed, but I try to say like maybe it was unsuccessful, like we weren't getting to the goal that we wanted. And so to call it that, you need to have a Bishop score greater than or equal to, or less, sorry, greater than or less than 6, greater than 6 for multiple, for multips, and 8 for nullips or people that have never had a baby before starting the induction, for any non-medically indicated or elective inductions. And then you need to also have oxytocin needs to have given 12 to 18 hours after rupture of membranes without any cervical change or regular contractions. At least 24 hours of oxytocin given after rupture of membranes, preferable if there's maternal or fetal, if maternal or fetal status permits. And that even gets a little more complicated because like you need to have to call it like failed, or like you want to also think about, and this is also true for like even like labor, when people are just like laboring with Pitocin, or like even not Pitocin, like thinking about like what is the strength of your contraction. We would have to like actually measure that, and that's where we'd put in like an IUPC, intrauterine pressure catheter, to be able to like measure like, okay, you are like your uterus is like the strength of your contractions is adequate, and so you've had adequate amount of time with this adequate amount of strength of contraction to say, this is like, you're not going to progress in your labor anymore. Induction is a little bit different than that, but it's kind of like similar thinking, to really officially call it an unsuccessful induction. And then I hope this works. Okay, so like what, let me pause it for a second. Like I was saying before, I don't do a lot, I don't scrub into a lot of C-sections. Like if one of my personal patients goes into a C-section, I do scrub in for those, and I'll sometimes just be there to be able to talk. I was a doula for 10 years, and like I remember my first delivery went to C-section, and I got to like scrub in, and I stayed by mama's head, and like and was like also like kind of right, they had a curtain up, and so I was able to describe everything that was happening, describe like, she's got dark hair, I can see her hair, things like that, because she can't see it, and being able to provide that context for her while she's on the other side of that process. And but generally in my typical practice, like when I'm on my rotation, like I don't go into the C-sections because I'm doing other things on the deck. So I don't have like a lot of great information for you, but if this is something that you are interested in, like getting more information on C-sections, I can maybe reach out to one of our OB fellows to kind of maybe create some more information for you. But I actually really like this video that actually Dr. Thompson had told me about, and it's a mom that was describing a C-section to her kid, and it's actually like pretty medically accurate as well, and easily digestible. So let's see if it works on here.
We're going to check to make sure that the anesthesia works. So you could go ahead and just pinch the tummy, see if the patient felt it. Does the patient feel it? Nope. Okay, we're good to go. We're going to start by making a transverse incision on the lower part of the belly. What do you see? went through the skin and the fat. Very good. This is the fibrous fascia. Now here's the rectus muscle. So we're just separating the muscles to the side. Okay, go ahead. Separate to the side. So this is going to be our bladder blade. Keep it here to protect the bladder, which is under here. Here's the uterus. We're going to cut through the uterus. Yep. So that's the amniotic fluid, which is inside the amniotic sac. Do you see the baby? Do you think we can get him out?
Stick it really deep.
Oh my goodness. Okay. It's coming out.
I'll help.
Okay, we have a head. Okay, all right.
It's a Spider-Man baby.
So here's the baby. Congratulations. So baby's so cute. We have to deliver the placenta next. There we go. There's the placenta.
That was interesting.
Talk about a high achiever. Yeah, that kid is doctor for sure.
You know whose mom is the doctor, don't you? Yeah. That's really cute. I have when I do the doula training, I have this awesome video. It was done a few years ago in somewhere in Africa, I think, but they talk about a bunch of randomized trials and what worked and what didn't. So it's just, I mean, you can tell it was meant for medical students, but I always like to show that. And it is on actual, it's graphic and everything, but yeah, interesting. Thanks for sharing that.
Yeah. So that's the end of our talk for this this month. What other questions were lingering, or that we didn't we didn't really touch on, that you are like, hey, I'm so confused about this, or can you speak more about that?
I'm just wondering about the two different types of C-sections. You said the classic one is for emergency use. And I was just wondering, what would, I guess, what is it doing that the other one, you have to apparently get in there fast, but yeah, I guess why not the other one, and why this one? You said emergency. What constitutes that use for emergency?
I think actually, so like a crash C-section situation in a trauma situation, cardiac arrest or something like that, in the field, or in the ED, in even in urgent C-section situations. I mean, on the if you're in an induction and something happens, or if you're in labor and something goes terribly wrong, and we're we need to go to C-section immediately, they're still not going to do that vertical incision. Like the OR is very controlled. These are like trained surgeons that are like know how to get a baby out very fast, using the typical like transverse section like they did here in this video. I like these are like methods that are used sometimes in the field in trauma situations, you know, where they're like, we need to get this baby out right now. We don't have time to go to the OR or something like that. Or, you know, depending on like if you had a baby like outside of the US, depending on the training of the surgeon, you know, those like exactly like I have seen that situation where that's just what happened in that, you know, in that particular situation. That was how the training was where they had their baby.
I think recently, at least in my experience, I have seen an increase in the number of classical C-sections, but it comes out of people who have been mostly in refugee settings and refugee camps. So whether that's, you know, from where those providers were educated or what resources they had available or what the situation was, I don't know, but all three of those, you know, could have come together to make it so that the classical C-section was something that needed to be done at that time. You know, the issue with the classical C-section is that in future pregnancies, you have a higher likelihood of rupture or creta just because the scar is bigger. And that's where the baby lives rather than closer to the bottom of the cervix. So that's why we would try to avoid it if we have that ability to do so. And I think that anybody who is taking the time to think about whether to do a transverse or classical is probably going to do a transverse. But if it's at the point where you're not really thinking about which cut am I doing, then it's probably the point where you do in the classical.
Other things that could I wanted to Google it really quick too as well to kind of refresh my brain, but like issues with the uterus, if there was some reason why they couldn't, like anatomically getting the baby out in the low transverse was going to be difficult. In for some reason, there's like so many different reasons, like maybe like body habitus or something else is going on, or maybe there's some issue with like the lower segment of the uterus, like a tumor or, you know, something like that, fibroid, then they might want to go up higher. Previous surgery or something, you know, there's different indications. I mean, most of the time, they always try to do the low transverse, even on repeat C-section.
Yeah, I think abruption with like some, you know, hemorrhaging. I think there was a client I was with years ago who ended up having hysterectomy as a result of placenta abruption too. And I think they might have done a classical one just because it was happening so fast, and just it was crazy how the contour of the belly changed, you know, and she was just in this like excruciating pain, and I think in situations like that is what I've seen, and I think she's had a classical. I'm not 100%, but that's what sort of came to mind. One last thing, and I know we have to let you all go because we're like more than into our hour, is I wanted to ask about how frequently you all use the, speaking of, you know, the calculators, how frequently do you all use the VBAC calculators?
Oh yeah, every time somebody wants a VBAC, they like our protocol at Swedish is that they need to either meet with Dr. Kevin Wang, who works at our clinic. He's a family medicine doctor that is trained in cesarean sections. And he could do a VBAC or trial of labor consult. If he's not available, we send a patient to have a consult with maternal fetal medicine, and they go over the same information that Dr. Wang does. They talk about the risks and benefits. They talk about the calculators, and like majority of the time, when someone wants to do that, like they were saying, yeah, this is safe. This would be, a reasonable option for you to do a VBAC. And some people had a cesarean and they have no desire to do a vaginal delivery after their cesarean, and that is totally fine. That's up to them, and I support them in whatever decision that they want to do, and I'll still be doing their prenatal care, and if I was able to make it to their delivery vaginally, I could still make it to their delivery for their scheduled C-section. I wouldn't be doing it, but I'll still be there for them, and I'll be rounding on them afterwards and seeing that both mama and baby, or parent and baby, like at their 6-week visit and baby visit.
Perfect. Well, I think I don't see any hands up. This group has been really good at having their hands raising their hands when they had questions. So this was really awesome, and thank you so much. And sorry for taking a bit more than an hour of your time today. So yeah. Awesome.
Want to talk about next month?
I don't know. The group here, is there anything, a burning topic that you all want to have our doctors cover next month, or do you want to chew on it and let us know in our WhatsApp group, whichever is fine with me.
I think chew on it is pretty good to me.
Yeah. Okay. Oh, okay. I like a VBAC topic if optional. Taylor says. All right. Thank you, Taylor.
Sure. Well,
yeah.
You let me know. I can start like preparing for VBAC presentation, but give us a heads up so that we just have enough time to prepare. But for now, I'll start the VBAC process.
Okay.
If there's like, in the next week or so, you're like, we want to talk about this, then.
Yeah. Okay. Yeah, I think VBAC is a hot topic. Definitely one that most of our doulas deal with. As well. So, okay, then unless we let you know otherwise, maybe let's just go with that for now, and then we'll go from there.
All right.
Sound good? Yeah. All right. Thank you so much.
Again. Bye.
Yes, definitely.
See you. Bye.
Thank you. Thank you, everyone, for being here. Bye.
Yeah, bye.